Let's review why we bother putting catheters in the heart in the first place. The main reason is so that we can record small signals from inside the heart that are not seen on the surface EKG. For example, from the bundle of His. If you put a catheter inside the heart, right next to where the bundle of His is located, at the tricuspid annulus, you can record a small deflection. But because the mass of myocardium being depolarized is so small, it can't possibly generate a signal on the surface EKG, so it's invisible. Similarly, during an arrhythmia such as ventricular tachycardia, you see the surface QRS complexes that reflect the bulk of the myocardium being depolarized, but something has to be happening between the QRSs if it's a reentrant rhythm. And it's only when you put a catheter inside the heart in an area of myocardial scar where there are small slips of live but sick myocardial tissue being activated slowly between the QRS complexes that we can finally record them to see what is their location and to direct catheter ablation. And during any rhythm, if you see fractionated signals that are very small, it can tell you that this tissue you're sitting against is made of myocardial scar interspersed with live but sick and slowly conducting myocardial cells that can be the substrate for reentry. If it's a small amount of mass, then you're again not going to see these signals on the EKG surface. It's important sometimes for us to record the timing between signals. For example, when we look at the surface PR interval, that doesn't tell us how much of that interval is made up of electrical signals traveling through the AV node and how much is traveling through the His-Purkinje system. But when you can record an intracardiac His bundled potential, you can now split up that PR interval into two components. The first part, the segment that goes through the AV node, and the second part, the signal passing through the His-Purkinje system. And that can be important in detecting certain disease states, especially when there is clinical evidence of signals not able to get from atrium to ventricles, and you want to know the consequences of that second-degree AV block. And lastly, we want to look at the activation sequence. We can often guess where the origin of a signal is coming from and where a wavefront is headed by looking at the surface EKG, either the P wave or the QRS. But if you want very detailed information about how a wavefront is traveling across myocardial tissue, we put catheters in the heart and record from multiple sites. So for example, during sinus rhythm or during pacing, we can figure out how the atria and the ventricles are connected to each other. Is it only through the AV node, or is there an accessory pathway present? And if there's an arrhythmia occurring, such as atrial flutter or a focal atrial tachycardia, we can really pinpoint with high precision by recording bipolar electrograms from multiple sites in the chambers of interest, the exact timing to define where the circuit is located or where the focal tachycardia is coming from. If we are to fully appreciate using intracardiac catheters, the way wavefronts move through cardiac tissue, you need to be recording local potentials at multiple positions at once. This means putting multiple catheters up in the heart, and each catheter that you place usually has multiple pairs of electrodes on it. The catheters are strategically positioned at locations where we want to know the timing of activation. For a moment though, in this image, let's forget that 4 of these 5 catheters are even present and focus just on one of them. This catheter is sitting in the coronary sinus between the left atrium and the left ventricle along the posterior aspect of the mitral valve. And here I've outlined roughly in this LAO view where the left and right atria might sit. If you were to record from these 5 pairs of electrodes that I'm arbitrarily labeling A through E, A sitting at the interatrial septum and E sitting at the lateral aspect of the left atrium, and a single beat occurred, and here are the recordings during that beat, we can see right away, instantaneously, that because the signal was inscribed at position A, followed by B, then C, then D, then E, that this beat must have originated rightward from the electrode pair labeled A, meaning from the interatrial septum or from the right atrium. If there had been a signal that originated from the lateral aspect of the left atrium and traveled in this direction, then we would have seen the bipolar recording in E first. If there had been a signal originating from the left atrial roof that then came down and activated the floor of the left atrium, you would have seen perhaps more simultaneous activation of all of these pairs of electrodes rather than sequential. So you can see the power of recording from multiple places at once. In this case, only 5 pairs of electrodes in the coronary sinus. Imagine what you can do with more catheters in place, and also a roving mapping catheter recording multiple sites beyond where fixed catheters are positioned. The more catheters that are advanced up into the heart, the more data will be displayed on the screen at the same time. So it becomes very important to label every electrogram channel so that you know exactly what catheters are in the heart, where they're located, and what electrodes are being viewed. Here are some standard labels that are used when you see multiple channels on the screen at the same time to keep things organized. HRA stands for high right atrium. HIS or HBE stands for the HIS bundle electrogram catheter. RVA stands for right ventricular apex catheter. CS stands for coronary sinus, where typically a decapolar 10-pole catheter or a 20-pole catheter is placed. ABL stands for the ablation catheter. Duo or RA is used usually to represent a 20-pole catheter that can be looped around the circumference of the right atrium, typically during flutter procedures. Halo is another type of 20-pole catheter that has a slightly different shape that's also looped around the right atrium and is also used for flutter procedures. Lasso or spiral stands for a much smaller circular catheter, usually with 10 or 20 electrodes on it, that's positioned inside a vein, usually a pulmonary vein in the left atrium during AFib ablations, or sometimes in the superior vena cava if that structure is being targeted. Penta stands for pentaray, which is a 5-pronged starfish-like catheter that has a total of 20 electrodes on it as well, and is used in various chambers when you want to record multiple bipoles at the same time. There's a consistent way that we number the electrodes on all catheters, and that is starting from the end of the catheter and working backwards. So the distal electrode in all catheters is always known as electrode number 1, and then working backwards depending on the number of electrodes that exist. When you have a simple catheter like this quadrupolar catheter, we sometimes talk about pairs of electrodes instead of the numbers. So we may call this pair the distal pair of electrodes, the mid pair of electrodes, or the proximal pair of electrodes. So for example, if you have a high right atrial catheter, you may see a label on the screen, HRA-D, that suggests you're talking about the distal pair of electrodes, or a HIS bundle catheter, HBE-M, that's the middle pair of the quadrupolar catheter positioned at the HIS. When you have many more electrodes than 4, we generally deal with numbers, again numbering from the end of the catheter backwards. So in this 20-pole catheter, you'll see a label Duo 1-2 or Duo 9-10, and that'll tell you which pair of electrodes you're dealing with in that recording. And same thing with a circular catheter. Even though it's a circle, it still has an end. So we'll number the electrodes from the distal end backwards, starting at 1 and in this case ending at 20 because it's a 20-pole catheter. Ablation catheters are quadrupolar catheters, and they're typically labeled in 2 electrode pairs. So if you see ABL-D, that's the distal pair of electrodes, which includes the ablation electrode itself at the catheter end. When we're dealing with unipolar recordings, we will number these electrodes 1 through 4, so it's important to know that distinction when looking at ablation catheter electrograms. So where do we position catheters in the heart during a standard electrophysiology procedure? We take into consideration the normal activation of the heart, starting at the sinus node, sweeping across the right and the left atrium, going ththrough the AV node and the His-Purkinje system, and we position catheters at places that are accessible from the right side of the heart, because typically we don't like to enter the femoral artery if we don't have to. We don't like to enter the systemic circulation if we don't have to, but we do like to record from strategic locations nonetheless. So typically we'll position a catheter in the high right atrium near the sinus node where beats start. We'll position a catheter at the His bundle electrogram, as we discussed before, so that we can assess atrioventricular conduction. We position a catheter down in the ventricles, in the right ventricular apex, so that we can assess ventricular activation. And so that we can look at the left side of the heart, we take advantage of the coronary sinus, and we position typically a 10-pole catheter with 5 pairs of electrodes in the coronary sinus to record the left atrial activation. Here is an RAO and an LAO view of a standard electrophysiology setup where you have the high right atrial catheter positioned in the high right atrium as seen in these two views. The right ventricular apical catheter extending toward the right in the RAO view and coming straight out at us in the LAO view. The His bundle catheter positioned right at the tricuspid annulus on the septum. And the coronary sinus catheter going into the screen in the RAO view and traveling leftward in the LAO view. And because of the way the heart activates during sinus rhythm and what's accessible from the femoral vein, these typically are the places that catheters are positioned during a standard EP study. Let's keep moving forward now and look at how electrograms from multiple channels are displayed on the screen at the same time and get into the information that they provide. First, let's talk about the speed with which signals are displayed on the screen. On an EKG, we call this paper speed. Obviously, electronically, there's no paper involved. But let's quickly look at displaying information at different speeds on the screen. We're used to seeing on an EKG a 25 millimeter per second paper speed. And that's what's shown here, including multiple intracardiac channels. And the surface EKG looks exactly like we would expect in the top 3 channels here. The problem in the electrophysiology lab is that if we display our electrograms at this same relatively slow speed, then you're going to see a lot of electrograms appearing to be simultaneous, and figuring out what comes before what and measuring the timing between intervals can get very difficult because everything is squished together. As a consequence, we actually display usually at 4 or 8 times that speed on the screen in the EP lab, so it looks something like the image on the right, which is shown at 200 millimeters per second. So now the surface EKG looks a little funny because it's stretched out horizontally. However, the electrograms are stretched out as well, which can be very helpful when we're talking about measuring intervals between one electrogram and another, or looking at the sequence of things, which is much clearer now that we've stretched things out compared to the image on the left. When multiple channels are displayed at the same time on the screen, usually people will have a specific sequence that they'll use so that you can see the same pattern over and over again to recognize normal versus abnormal electrical conduction through the cardiac chambers. Usually at the top, the surface EKG leads are displayed, followed by a sequence of electrograms that usually rely on the sequence in sinus rhythm, so that the high right atrial catheter is displayed first, signals travel across the right atrium and reach the bundle of His catheter, and then they travel across the left atrium, so the coronary sinus electrodes are displayed, and the beat gets down to the ventricle so that the right ventricular apex is usually displayed at the bottom. Sometimes people will display the coronary sinus catheter with 910 at the top, because then you'll get a sequence that is top to bottom in terms of how sinus rhythm transmits across the heart. Other people like to use the numeric version and put 1-2 at the top, in which case the signals will have a bottom to top sequence in sinus rhythm. Some people like to group different electrograms together, for example here on the right, so that your eye can track patterns in a little different way. So here the His bundle recordings are grouped together, the coronary sinus recordings are bundled together, and it's just individual preference whether or not to bunch the electrograms that are from the same catheter together, separating them out from adjacent catheter electrogram tracings. When we print out snapshots and present them on screens like this, we usually get a black and white version. But in the EP lab, we have additional features at our disposal to make things easier to see and sort out, and that includes coloring the electrograms. This is the color system that I personally use, where I will display the high right atrial catheter in green, the His bundle catheter in yellow, the coronary sinus in white, and the right ventricle signal in lavender. But everybody has their own preference, and there have been some debates about what is the convention, and there really is no convention. It's whatever makes you comfortable, but using the same pattern over and over again makes things much easier when you interpret electrograms during an EP procedure. Let's review the electrograms that will be recorded by the 5 pairs of electrodes in this decapolar catheter that is positioned across the tricuspid annulus, spanning from the right atrium toward the right ventricle and passing the bundle of His. If you look at the drawing in the top right, I'm going to show now where this decapolar catheter is sitting. And we can use that drawing to understand the 5 electrogram patterns that are recorded from these pairs of electrodes. I'm going to actually show the surface EKG so that we can better understand the timing of the electrograms compared to what's going on in the heart as a whole. If we start here at the 9-10 pair of electrodes, we can see that it is sitting in the right atrium, and it's far enough away from the His bundle and the right ventricle so that it's only recording an atrial electrogram. This times with the surface P wave, and maybe you can see a far field hint of a signal that times with the QRS complex, but mainly this is sitting in the atrium and recording an electrogram that's appropriate for that location. As we move to pair 7-8, this is now positioned right at the annulus and right near the bundle of His, so that we actually see 3 different electrogram inscriptions on this channel. An atrial electrogram that times with the P wave, a ventricular electrogram that times with the QRS complex, and in between the two during the PR segment we see a 3rd recording, and this represents a direct recording of the bundle of His. As we move forward toward pair 5-6, we start moving away from atrial tissue, so we're getting more of a far field small signal that times with the P wave, a larger ventricular signal that's actually clipped. We actually limit its size, and that's why it looks squared off here at both ends. And we're still recording a His bundle potential between the P wave and the QRS complex on the surface. As we continue to move forward, we actually see a small signal that's a little bit later than where the His bundle signal was, and this is probably a signal from the right bundle branch, which runs along the inner surface of the right ventricular septum, and of course we still see a ventricular signal timing with the QRS. Lastly, as we move toward pair 1-2, we see only a ventricular electrogram, having moved far enough away from the conduction system and the atrial tissue that we no longer see electrograms from those structures. Let's now analyze a multi-channel recording that's about as simple as we can get in the EP lab. Here we see at the top 3 surface EKG leads labeled on the left. We have a catheter in the high right atrium giving us an electrogram here near the sinus node. We have a quadrupolar His catheter, and we're displaying 2 of the 3 pairs labeled mid and distal, and we can see the atrial, the His, and the ventricular signal as we reviewed in the previous slide. And we have a catheter that's all the way down in the right ventricular apex, showing us a ventricular electrogram that times with the surface QRS. Why is it important to record a bundle of His? We discussed this earlier when we talked about dividing up the PR interval into its two components, the AV node part and the His-Purkinje part. As signals travel from atrium to ventricle, of course, it must travel through the AV node first, and then to the His bundle, and then down the bundle branches in the His-Purkinje tree. On the surface, though, of course, we can only see the P wave and the QRS, and none of those structures in between. So when we record a bundle of His shown here, that gives us a halfway point, which actually isn't halfway because it usually takes longer to get through the AV node than it takes to get down the His-Purkinje system because those different parts of the conduction system behave very differently. But now we can measure the time it takes to get from local atrial tissue through the AV node to that His bundle, and this is known as the AH interval, A for atrium and H for His. And we can measure how long it takes to get from the His bundle down to the beginning of the QRS, known as the HV interval, from the His bundle down to the ventricle. And in this way, we can look when patients have a long PR interval or evidence of AV conduction block where the problem is located, because if there's a problem with the AV node versus a problem with the His-Purkinje system, there are very different implications in terms of the timing of progression and the safety of the patient dictating the necessary treatment. So let's start getting comfortable with looking at intracardiac electrogram recordings when there are multiple catheters in the heart and more than one beat on the page. The simplest and most straightforward electrophysiology studies involve 3 catheters placed in the heart, one at the high right atrium, one at the bundle of His, and one in the right ventricle. And let's use this example of second-degree heart block to show how these recordings can be useful. Here is a surface EKG from a patient with second-degree heart block showing 5 P waves and 4 QRS complexes. P wave number 4 does not conduct successfully through to the ventricles. And we can see that the PR interval is gradually prolonging before the dropped P wave and shortens back up afterward. This is a classic AV Wenckebach pattern. If we add the intracardiac recordings from those 3 catheters I mentioned, this is what we'll see. The first thing that's most important to recognize is which electrograms couple with which beats on the surface EKG. And as you get more experienced, you'll learn to do this automatically. But I'm going to help you with this particular example by boxing in each individual beat along with its intracardiac electrograms. The first thing to note is that the high right atrial channel shows a deflection that times with the P wave in each of these 5 instances. And then the right ventricular electrogram times with the surface QRS, and there are 4 of those, with the 4th beat being absent. And then, as we reviewed before, the His bundle electrogram, which records signals from the atrium, the ventricle, and the bundle of His itself, because all of those are within the field of view of this particular bipole. And I'm going to label those for you right here. Notice that as the PR interval prolongs on the surface, it is the AH interval on the intracardiac recordings that is prolonging, where the HV interval is staying constant. This tells us that the point of prolongation is in the AV node and not in the His-Purkinje system. On top of that, notice that on beat number 4, there's actually no His bundle deflection, suggesting that this P wave blocked in the AV node before the signal even got to the bundle of His. Those findings combined tell us that AV Wenckebach, when it is seen, is caused by delay and then block in the AV node in this case, and not in the His-Purkinje system. Let's add yet more intracardiac electrograms to the display. We can see here, going from top to bottom, that we have on the top 3 surface EKG leads as labeled, a high right atrial catheter with a signal that times with the surface P wave, a His bundle catheter, and we're showing the proximal, mid, and distal signals as labeled. Now we have a coronary sinus catheter in place that records signals from the left atrium, because that's where the coronary sinus runs. In addition, there are some very small far-field signals from the left ventricle base. And then lastly, we have a right ventricular apex catheter with that sharp electrogram timing with the surface QRS. Notice that the way this is displayed is consistent with signals traveling from the sinus node across the right and then the left atrium, giving us electrogram depolarizations that go from top to bottom and left to right. Again, as I mentioned in a previous slide, some people like to order things differently on the screen, but this is my particular preference. So the high right atrial catheter is activated first in sinus rhythm. The signal sweeps across the right atrium and is then recorded in the His catheter, which is at the low interatrial septum. And then as the signal sweeps outward across the left atrium from right to left, we have deflections in the proximal pair of electrodes CS910, then 7-8, and all the way out to 1-2. Then, as the signal travels through the AV node, that's reflected in this AH interval, the signal gets through the AV node, reaches the His bundle, where you see a His bundle deflection, and then gets through to the ventricles, creating a surface QRS, deflections on the His catheter, which can see the base of the ventricle in its field of view, and also the right ventricular apical catheter, which is, of course, positioned in the ventricle itself. It's important to recognize what a sinus beat looks like so that when you see other beats, you can compare and contrast them to this template. Here are two beats on the screen, and I'll ask you to think for a moment, if you want to hit pause, which beat reflects what type of cardiac event. I'll tell you now at the outset, the second beat on the page is again a sinus beat, and you know that because on the surface you have a P wave in front of a relatively narrow QRS, remembering the fast paper speed, and you have a sequence in the atrial signals going from high right atrium near the sinus node first, traveling across the right atrium, and then traveling across the left atrium, and then the His bundle deflection, and then the ventricular deflections. If you look at the first beat on the page, however, you'll notice first on the surface the QRS is wider, suggesting that this is not traveling down the full His-Purkinje tree or using it at all. And the next thing you may notice is that the atrial events, which we know clearly look like this on beat number 2, the sinus beat, in this case are coming later than the ventricular events. Notice the first event to happen is in the right ventricular apex catheter. All of this information combined suggests that this beat is a premature ventricular beat, a PVC, because the events start in the ventricle, not the atria. So the ventricular electrograms happen first, and then that beat happens to conduct retrograde back up to the atrium through the His-Purkinje system, up through the AV node, and initially to the interatrial septum near the bundle of His recording, which is why the atrial signals in the His catheter happen first. The signal then simultaneously travels right to left out toward the left atrium, as you can see from the deflections in the CS catheter, but it's also simultaneously sending a wavefront across the right atrium back toward the high right atrial catheter near the sinus node in the superior vena cava. So these happen more or less simultaneously, but later than the septum is activated. The reason that we know this beat, of course, is not a sinus beat that happens to occur on top of the PVC is because the high right atrial event happens late rather than early. This is the sequence we would have seen if this were a simultaneous sinus beat on top of the PVC. Here are 3 beats on this page, and maybe hit pause and reflect for a moment if you can identify what is the nature of these 3 beats. Because there are 3 and 2 of them are close together, I'm going to start by showing you which signals belong to which beat. And the next thing I'll point you to is that beats 1 and 3 look very familiar. In fact, those are both sinus beats, and you can tell again because of the activation sequence in the intracardiac electrogram channels with the high right atrium first and so on, as we've discussed twice before. The second beat, however, shows a narrow QRS that happens after a P wave, But notice that the activation sequence in the atrial electrograms is different. Now you might say, well, this looks like the previous retrograde conduction after a PVC that we saw in the previous slide, but this is not a PVC because we have a skinny QRS, just like in sinus rhythm, which follows the atrial events and follows the His bundle recording. So instead, this early beat is a premature atrial beat, a PAC, and we can pinpoint more or less where it's coming from the few electrodes that we have in the heart. We can see that the septum, the low septum, is activated before the high right atrium and before the left atrium. So this is a PAC coming at least closest to the His bundle catheter. So probably coming from the interatrial septum, or possibly low in the right atrium, much closer to the His catheter than the HRA catheter. So this is what a PAC would look like that's originating from that location. And lastly, here are two beats on this page, and by now you're an expert and you can tell that beat number 2 is a sinus beat for all the reasons we've discussed. And you can tell that beat number 1 is not a PVC because the atrial events happen first, and the QRS is skinny, just like in sinus rhythm, and it follows the atrial events and the His bundle deflection. But now the earliest atrial activation is way out over here in the left atrium towards CS34 or CS12. So this is a premature atrial beat that is happening and originating from the left atrium rather than the septum, and certainly not the sinus node, because here the high right atrial catheter is activated at the very latest. So we can tell it's an atrial event, and we can more or less tell the region of origin from looking at the electrogram sequence from the locations that we're recording from. Let's go back and actually think a little bit more in depth about AV connections. I showed you in the last module this example of AV Wenckebach on the surface EKG and how it correlated with prolongation of the AH interval, the time it took to get through the AV node, and how on the P wave that doesn't conduct, there's no His bundle recording because the signal blocked in the AV node above the level of the bundle of His where that recording is made. Let's contrast that example with this one, another patient with second-degree heart block. And you can see from the surface EKG here, there are two P waves, and the second one conducts down to the ventricles, creating a QRS, but the first one does not. Let's see what the intracardiac electrograms look like. Here we can see that both P waves are, of course, associated with atrial deflections. We can see that here and here, those time with the P wave on the surface. And both beats, the blocked and the one that conducts, also have a bundle of His recording, seen here and seen here. But the first beat that blocks has no ventricular electrogram, which is not surprising because there's no surface QRS, compared to the second beat where there is a ventricular electrogram that times with the surface QRS. So what we can see here is that the blocked P wave clearly sent a signal that got through the AV node to the bundle of His, and then it was beyond the bundle of His that the signal blocked and didn't get down to the ventricles. This is known as subnodal block, below the level of the AV node, and in this case below where the bundle of His recording was made. And it's important to distinguish block in the AV node from block below the AV node because the former tends to follow a more gradual course that tends to be a little more benign in the short term, whereas the latter, block below the AV node, can suddenly result in AV block with asystole or prolonged pauses that can be even life-threatening, if not simply causing syncope with injury. So an intracardiac recording can verify what we might have guessed from the surface EKG pattern, comparing Mobitz 1 AV node level block versus Mobitz 2 below the AV node in the His-Purkinje system. The other point I wanted to make on this slide is to note that on the beat that conducts, the HV interval is actually quite long. And let's review what I mean by long on the next slide. Normally, the HV interval with a normal His-Purkinje network is about 40 to 60 milliseconds. And in this case, it actually is about 100 milliseconds, which even though it's only 40 milliseconds beyond the upper limit of normal, for a His-Purkinje system, that's really, really abnormally slow, suggesting disease in the His-Purkinje system, even if we hadn't seen block occur. And for comparison, here's a normal HV interval of 40 milliseconds. So if we were to see somebody with very long HV conduction time, we actually would recommend a pacemaker because a sick His-Purkinje system can potentially suddenly fail, leaving a patient with an absent or an extremely slow heart rate at an unpredictable timetable. What about a short HV interval like in this case? I've labeled in the His catheter the A, the H, and the V deflections. And if we measure the His bundle deflection to the very earliest part of the surface QRS, which starts here, I told you normal is about 40 to 60 milliseconds. Here we're only 5 milliseconds. And the question is, how is that possible? Remembering, of course, that the HV interval reflects the time it takes after the signal gets through the AV node to then get down the His-Purkinje system. Well, is it possible that this patient has super duper fast conduction down the His-Purkinje system, so instead of 40 milliseconds it can race down in 5 milliseconds? And the answer is no, that doesn't happen. So the only way to explain a short HV interval is that the ventricles must have been activated in a way other than through the normal conduction system. This can happen in two predominant fashions. One is there could have been a PVC that happened to occur smack on top of a sinus beat, but sooner than conduction would have activated the ventricles. Or in this case, you could have gotten from atrium to ventricle through a different route other than the normal AV node in His-Purkinje network, that being an accessory pathway. So there are two things happening in parallel. While a wavefront is passing down the AV node and down the His-Purkinje system, also a second wavefront is able to conduct from right atrium to right ventricle, or left atrium to left ventricle, or in the interatrial septum to the ventricular septum, and that can happen much faster than the delay that normally results from going down the AV node and then down the His-Purkinje system. So when you see a short HV interval, especially if it's on every single beat, you should be thinking that there's an accessory pathway present. Let's now think about how the ventricles are electrically attached to the atria. It's important in any full EP study to look at retrograde conduction and not just anterograde conduction. Sometimes there's an accessory pathway that's only capable of conducting in one direction, and usually that's backwards from ventricles to atria. And if you only did atrial pacing, you might miss the fact that there's an accessory pathway present. So you have to do ventricular pacing in order to detect what's known as a concealed accessory pathway that only conducts upward. This screen initially may look a little bit confusing, and I'm going to eliminate some of the electrogram channels for you because they're not important to the question that I'm asking right now. In the future, as you get more comfortable looking at electrogram screens, you're automatically going to draw your eye toward the electrograms of interest and ignore the ones that aren't important for the question you're asking at that moment. There's ventricular pacing occurring in this image, reflected on the surface with little pacing artifacts before each wide QRS, and also there's a channel at the bottom that shows us that pacing is occurring. If we look at the atrial activation sequence, we can see the very first atrial electrogram that's shown is in CS910, and then the wavefront travels leftward out toward CS12, the lateral left atrium, but also at the same time it travels laterally to the right toward the high right atrial catheter, which is also late.